So for this patient population, which is really, I've had adjuvant endocrine therapy. I've progressed now within roughly a year on first-line endocrine therapy. We really don't have a study that helps us with big decision-making like, is chemo better than an anti-estrogen strategy? At least in my own practice, I try to milk out as much as I can out of the anti-estrogen strategies before going back to chemotherapy in incurable metastatic breast cancer. But that's more based on minimizing the toxicity and hopefully prolonging the benefits of what I do for patients facing stage 4 breast cancer. So we have very little data about should we switch to anti-estrogen therapy or stay on anti-estrogen therapy, or should we switch for chemo. But my bias, unless you really have to see a very quick response, would be to continue to utilize anti-estrogen strategies. Likewise, we don't really, for this particular patient who's had a type 2 aromatase inhibitor and fulvestrant, we don't really have a study that says what is best. Is it best to go back to a type 2 AI with a targeted agent, which many people would at least consider in the use of CDK inhibitors? Or is it best to switch to a different anti-estrogen therapy, which exemestane is different than anastrozole, which the patient had received previously, and everolimus? We don't have any clinical trial data, nor do we have any molecular markers that really say, okay, if you have a PI3 kinase inhibitor, you should go on this, and if you have a CDK amplification, you should go on this. With that said, my bias is to switch to an anti-estrogen that the patient hasn't had, as opposed to go back to the anti-estrogen like this patient had letrozole, So in this patient who had had adjuvant anastrozole, my bias is not to go back to the same anti-estrogen, is to jazz it up a little bit and use a different non-cross-resistant agent. So we do know that exemestane works in patients who have had type 2 aromatase inhibitor, in this case anastrozole. I would also think about tamoxifen. I think people forget a lot about tamoxifen, and we do have very good data of tamoxifen being synergistic with everolimus, not necessarily in this line of therapy, but at least in the neoadjuvant setting, very good data that they work well together. So although there's, like many of the decisions we make every day in clinic, there's not a specific trial that this patient would have fit into, I think the switching to a non-cross-resistant agent is attractive to me. So in this case, exemestane or tamoxifen, and then adding a targeted agent where the data would suggest that everolimus could be added to either one of those agents.